Abdominal clinical examination. An introduction to abdominal inspection, part 1. This video is for teaching of surgery for medical students. Items of abdominal clinical examination. Inspection, palpation, percussion, auscultation, special tests and signs, per rectal examination in males or per vaginal examination in females, examination of the regional lymph nodes. Abdominal inspection. This video is specialized for part of abdominal inspection, part 1 of abdominal inspection. Items of abdominal inspection include body weight, patient's posture in bed, abdominal shape, abdominal regions, abdominal mobility, abdominal profile, subcostal angle, abdominal hair distribution, abdominal skin striae, visible peristalsis, abdominal pulsations, divarication of the recti, sites of hernial orifices, abdominal dilated veins, and this was done by a special video for abdominal dilated veins. Abdominal masses, abdominal scars, ascites, and the umbilicus. 18 items. We'll start one by one. Body weight. Average weight, overweight, or underweight. Underweight or overweight may be a cause of a disease or a complication of a disease. Patient's posture in bed. Normal posture, special posture. Peritonitis patients lie in bed without motility to avoid the increase of pain intensity. Renal pain patients twist themselves and move here and there due to the severe pain. Patients having orthopnea can't lie flat in bed Abdominal shape. Normal abdominal shape is symmetrically flat or slightly scaphoid. Slightly scaphoid. This is the shape of the scaphoid abdomen, concave to inside. Distended abdomen, convex wall. Abdominal distension might be generalized distension showing 5 characters. Each one starts by the letter F. 5 Fs. The first F is fat, obesity, fluid, flatus, feces, and fetus in pregnancy. All of these 5 Fs lead to generalized abdominal distension. Localized abdominal distension may be symmetrical in cases of small bowel obstruction, in patients having small bowel obstruction, or the distension might be asymmetrical in patients uh, having organomegaly like splenomegaly, hepatomegaly, or ovary in ovarian mass. Abdominal regions. The abdomen is divided into 9. The abdomen is divided into 9 regions by 2 vertical planes, right and left mid-clavicular planes, by an upper transverse plane, the subcostal plane, by a lower transverse transtubercular plane between the right and left iliac tuberosities. The abdominal 9 regions names are right and left hypochondrium, epigastrium in between, right and left lumbar, and the umbilical in between, right and left iliac, and the suprapubic in between. Each region contents are as follows. In the right hypochondrium, the liver, the right kidney, the gallbladder, large and small intestine. In the epigastrium, the liver, stomach, spleen, duodenum, suprarenal glands, and pancreas. In the left hypochondrium, the liver's tip, the stomach, pancreas, the left kidney, the spleen, and large and small intestine. In the right lumbar, ascending colon, small intestine, and right kidney. In the umbilical, duodenum, small intestine, and transverse colon. In the left lumbar region, descending colon, small intestine, left kidney. In the right iliac region, the appendix, the cecum, and the ascending colon with small intestine. In the suprapubic region, the urinary bladder, the sigmoid colon, the small intestine, and the genital organs, whether male or female. In the left iliac region, the sigmoid colon, the descending colon, and small intestine. Abdominal mobility. Normal abdominal mobility. The abdominal wall rises with inspiration and falls back down with expiration. The mobility is free and equal mobility on both sides. Abnormal abdominal mobility. It is absent or diminished abdominal mobility in cases of generalized peritonitis, leading to development of silent abdomen. No peristaltic waves are heard by the stethoscope. Abdominal profile. The vertical profile is observed by the side of the patient. We observe, we are standing or sitting at the side of the patient. The transverse profile is observed from either the foot end of the bed or the head end of the bed, like that. Abnormal abdominal profile, irregular. With generalized distension, with inverted umbilicus, we think of obesity or recent gas in the intestine. And with generalized distension, with everted umbilicus, we think of chronic ascites, neoplasm, or umbilical hernia. In the presence of a scaphoid abdomen, we think of malnourishment. And in the presence of distension of the lower half of the abdomen, we think of the presence of an ovarian neoplasm, presence of pregnancy, or presence of distended urinary bladder. Distension of the lower third of the abdomen, we think of pregnancy, uterine fibroid, ovarian neoplasm, or distended urinary bladder. Distension of the upper half, we think of carcinomatosis, pancreatic cyst, or acute gastric dilatation. Subcostal angle. The subcostal angle. It is a right angle in normal persons, and it is obtuse in patients having increased upper abdominal pressure, like the presence of large mass lesion in the upper abdomen. It is affected by chest wall abnormalities also. This is by inspection, we observe it by vision. And by palpation, we should palpate like that, the two thumbs at the subcostal margin to meet the angle in between. Abdominal hair distribution. Normal female hair distribution is triangular at the suprapubic region, with the base of the triangle upwards and the apex downwards, like that. No other hair in the abdomen in females. Normal hair distribution in males. In the female, the suprapubic is triangular, but in the male, it is rhomboidal. A triangle down and an inverted triangle over towards the umbilicus. The shape is rhomboidal. Yes, this is the pubic hair creeping up. This is a hairy male having the pubic hair, abdominal hair, pectoral hair in the chest wall. Abdominal skin striae. On distension of the abdomen by pregnancy, obesity, or big swellings, any cause of increased intra-abdominal pressure, the elastic connective tissue fibers are torn, with rupture of the capillaries leading to development of skin red striae called stria rubra. This is the shape of the stria rubra, reddish in color or pinkish. Recent. This means that these stria, red stria, are recent. After absorption of the blood pigments by time, fibrous tissue replaces the torn skin elastic fibers, leading to changing of the red color of the stria to be white in color. It is called stria alba. Visible peristalsis. With pyloric obstruction, with a small or large intestinal obstruction, normal in the elderly with lax abdominal muscles. This is an elderly person with lax abdominal muscles. The peristaltic waves are visible through the skin of the abdominal wall. Visible abdominal pulsations. Transmitted pulsations from a tumor like gastric carcinoma. Aortic epigastric pulsations are felt and seen in thin nervous individuals more. Expansile pulsations of an aneurysm. The aneurysm expands its wall, becomes distended, leading to expansion. It is called expansile pulsations. Venous pulsations of the liver may be seen. Right ventricular hypertrophy. The pulsations of the right ventricle might be visible in inspection and felt by palpation. Divarication of the recti. Midline gap between the medial borders of the two rectus abdominis muscles show bulging on straining, bulging of the abdominal wall on straining. A very classic midline between the two medial aspects of the rectus abdominis muscles. The gap on straining leads to bulging of the weak abdominal wall. Sites of hernial orifices. This is very important as a part of general examination in clinical examination of any patient for any disease and on abdominal examination. The paraumbilical hernia protrudes through the one pole of the umbilical cicatrix, whether the upper pole, which is commoner, or the lower pole, less common, of the umbilical cicatrix. The Spaghelian hernia protrudes at the point of junction between the lateral border of the rectus muscle or rectus sheath with the lateral border of the arcuate ligament separating the upper aponeurotic from the lower fascial posterior rectus sheath wall. The gluteal and the sciatic hernias. The gluteal protrudes through the greater sciatic foramen and the sciatic protrudes through the lesser sciatic foramen. Both of them are labeled in blue because they don't appear clinically except after development of complications and diagnosis after laparotomy, because these two hernias are covered by bulky muscles, which doesn't show it clinically. Femoral hernia protrudes through the femoral canal at the most medial compartment of the behind the inguinal ligament with the lacunar ligament and pectineal ligament. The obturator hernia protrudes through the obturator canal through the obturator foramen of the pelvic bone, and it is covered also by bulky muscles, and for that reason it is labeled by yellow label like the sciatic and the gluteal hernias. The incisional hernia occurs at any site of an incision in the abdomen, not for repair of a hernia. Development of a hernia at the site of repair of a hernia, it is a recurrent, but incisional hernia, it occurs at the site of an incision for any other laparotomy other than hernia repair. The epigastric hernia has another name, is better than epigastric. This fatty hernia of linea alba, defect in the midline linea alba. It is fatty hernia of linea alba. The lumbar hernia occurs in the lumbar triangle. The umbilical hernia occurs through the bulging of the whole umbilical cicatrix, the whole, not the border of the cicatrix, the whole umbilicus covering skin. It is the direct inguinal and indirect inguinal hernias. These are very important to know. These are 11 hernial sites should be known by any practicing physician, not surgeon only, because it is part of the general examination of the abdomen for any other disease. I have the pleasure to invite you to subscribe to my channel and visit it to view and select what you need. This is the link of my channel on YouTube. Good luck and best wishes.